So I'm S. Julianne Lloyd. I hail from Maryland, as I was just introduced, and I'm very excited to talk with you guys today about robotic surgery, AI, and automation. I'd also like to thank the organizers for extending the invitation and the opportunity to present today. So to start, I have no relevant financial disclosures. However, I should let you know that my practice is primarily robotic. I do a fair number of cases, especially revision cases on the robot. You can see the distribution of my cases here. In addition, I also used AI to generate some of these images that you'll see in the talk. So before we can talk about autonomous robots, I think that's really where everybody's mind goes to. Let's take a moment to really look at where we are now, honestly. We often ask if the robot is better, is robotic surgery better than laparoscopic? And I think it really depends on the realm you're looking at. So in a straightforward primary sleeve gastrectomy in a high volume center, the robot may not offer any incremental value. We already know that laparoscopy works very well. But in medium complexity cases, this is more situational. So especially when you're doing a lot of suturing, and it might help with education. I'll talk about that in a little bit. But I think really where the robotic platform shines is in complex procedures. It gives you better ergonomic, you have wrist instrumentation, there's a stable view using the robotic camera, there's technical precision, and especially when you're working with patients who have very, very high BMI, you're not balancing as much against the abdominal torque when you're using the robot. It usually absorbs most of that pressure. So I think robotic surgery offers a meaningful role in patients with high complexity cases, and it's not by magic. It's really because it's providing consistency as you're operating. So currently, we are relying on teleoperated robotic systems. They filter the tremor, they scale the motion, they improve visibility, but really the outcome of the case is still going to depend on the surgeon's anatomical understanding. It depends on the surgeon's judgment, on their experience. Are they able to recover from the case when it deviates from expectations? And this is really where AI and automation can help us in the OR. So in this really short video clip, it's actually a surgeon who is operating remotely, which I think is another benefit of robotic surgery. So if you think of it as different elements in the AI continuum, the first or basic one to look at is sensing. So the robot is recording everything that's happening. It's capturing the video, looking at the instruments that you're using, measuring your motion and force, and looking at your overall workflow. The next level above that would be where the AI is going to interpret the data. So it will recognize the anatomy that's on the screen. It can identify the different phases of surgery, and it can predict what's coming next. Or it can even flag when there's a deviation from the norm or if there's some kind of high-risk situation that's about to happen. So if we look at the spectrum of all different robotic cases that are being performed now across orthopedics, pediatrics, obstetrics, and gynecology, we can see that there have already been benefits with this implementation at the sense and think level. And these are what we've seen in terms of the quality of data. So we know that there's better intraoperative precision and control with the robot. There's reduced operative time. Even in oncological cases, there's better control in terms of surgical margin resection. So we already see that there are improvements with just using the typical system, and I think most surgeons now are probably operating with the intuitive platform. But the next level above that is really where I think we'll see so much benefit. And that's when the system becomes clinically useful through guidance, using alerts, checklists, different types of coaching, and even performance feedback. So this is actually the first AI-assisted augmented case that was performed. So they used CT imagery to define the anatomy that was expected in the case, and then use that as an overlay as the surgeon was performing the procedure. So it used structured video, instrument motion, energy activation, and it basically turned all of that data into insight. In another example, looking at robotic-assisted minimally invasive esophagectomy, The authors on the study evaluated papers that were published talking about looking at AI to improve this particular procedure. You can see there were a number submitted. And they divided the procedure into 9 different phases and used an AI model called Techno, which uses hierarchical prediction for surgical phases. And the performance was assessed by comparing how surgeons would actually split the different portions of the procedure into phases and compared that with what the robot did. And they actually agreed in 84% of the instances. So already I think the robots or AI is becoming so good at mapping the technology in the same way that humans could do it. But these studies are really early in the phase of technology. I think over the next 10, 15, 20 years, the robot is going to become even better. And unfortunately, I think it's probably going to surpass us in terms of its predictive capacity. So again, just to kind of summarize what we can expect in terms of benefits from the robotic platform. So lots of real-time intraoperative enhancement. There's noise reduction, especially with the camera, and de-blurring of the camera. In terms of motion stability, that's much better. And I think it will help us as well in training. So again, looking at our stack, the 4th level will be autonomy, which I think is what we are trying to achieve. And that's typically where the system performs a task. So in reality, this is probably going to happen in the next 5 to 10 years. For bariatric surgery or metabolic surgery, that means better perception for us, consistency in our outcomes, and even decision support as we go through. But that does not mean that the robot is going to be performing a gastric bypass or OAGB or SADI or whatever is your preferred procedure. I don't actually see that happening in the future, but I don't know. You guys can mark my words. We'll see what happens. But again, it's just going to be an improvement in some technology, but not a complete replacement of the surgeon. So if we look at all the systems that are currently available, they have different ranges of autonomy. So at the bottom of the screen, you have surgeons that are not platforms that are not providing any autonomy right now. As I mentioned, most of the procedures are being performed with the different versions of Da Vinci, and other industry partners have representation here, but nothing really in the fully autonomous section. So if we try to apply all of this against a typical case, I have it laid out here in terms of the care continuum. So if you think of, as I mentioned before, the robot really shines in revision surgery. So think about the typical revision that you might see, a patient who comes in and has had a sleeve or maybe even a band in the past and is struggling with some of these problems. The robot and using automation and AI in the future could potentially give us the best revisional path for treating this patient. So it will look at whether or not the patient is ready for revision, what types of tests you need to do, how do you optimize the patient. When you're actually performing the surgery, what do you see on the screen? What types of maneuvers do you need to perform to help ensure that the technique is done in the most efficient and safe way for the patient? And then afterwards, how do you optimize the patient's care in the post-op period? Should we be implementing medications, for instance? That's something that could also help us in terms of automation, in terms of the pathway. And I think ultimately what will happen is that as we continue to get more data on each patient, each case, that will help us to train the robots and train automation so that we can become better at predicting in the future. So in my mind, this is kind of what I see the future of robotics looking like. The surgeon is still the primary person who is managing the case, managing the patient's care. But in the background, there are all these little minions, minute robots that are helping us in every single path as we take care of the patient. Now, the other realm in which I think this could help us is actually training the next generation of surgeons. So traditionally, we look at training as making sure that enough cases are performed by the trainees. So case volume, are they spending enough time doing training? And the feedback is really subjective based on what the expert who's watching the trainee do. But as we move forward in time using AI, I think that our training is going to focus more on improving, providing trainee-specific feedback. And some of the technologies that are already in use, I don't know if you guys have heard about digital twin. So in the digital twin, the actual patient situation is simulated in real time. So as you're operating or doing a step, a task, the automation or AI is actually following you and providing real-time feedback. And this is something that can help our trainees moving forward. So it's not widely adopted yet, but I see this as being one of the major players in terms of training surgeons as they get better. But that does not mean, even with all of this, that we're going to forego laparoscopic and open surgical skills, because I think, unfortunately, we have to keep in mind that our trainees still need to be able to convert, be able to do an open procedure. I don't know when was the last time you guys did an open GJ, but I think it's a skill that is worth holding on to. And we have another talk later today about ethics, but I do want to take just a second to talk about this, because I think this is one of the things that we have to consider as we go through with AI in surgery. It has to become trustworthy for it to be widely adapted. Especially in the European environment, it's already moving in a direction where high-risk AI systems are being closely watched, looking at medical software, requiring transparency, oversight, and post-market marketing. So I think it's really important for us to maintain this for our patient safety. So even though it has to be validated in patients, it has to be safe for them as well. And these are some of the ethical considerations I think are going to become important as well. Who is training the model? Are we ensuring that the data is protected? Who owns the data? So I think we'll talk about this some more in one of the talks in this session. But what can you guys do now as we prepare for the next stage? I think it's important for us to gather data to train AI. So I would start recording your videos, making sure that they're done in an appropriate manner. Build governance and make sure that you present and talk about your experience at meetings like this so that we can be ready for the next stage. Now, there's many, many companies that are working on different robotic platforms. As I mentioned, it's not just going to be the hardware that's important. I think the automation and the AI part of it will also be critical in terms of developing intelligence. But what I foresee in terms of the future is that we'll be much more perceptive. We'll have an augmented reality using platforms like the digital twin. The robot will also help us with camera control, as I mentioned before. It will help with our training, and we'll actually get beyond teleoperations. So what I see is AI augmented surgery that is supervised by the surgeon. So just in summary, I think the robot provides precision, perception, and consistency, but we are still going to be important to provide judgment. Thank you.
Thank you for your presentation. Are there any questions from the stage? I have a small question to you. How far you think we are from the fully automated robotic surgery?
So fully automated, that's what I'm saying. I'm not sure that we'll quite get to that level, but in terms of as much automation as possible, I think probably another 15 years or so.
15 or 50?
15, not that far, in our lifetime for sure. Yeah. So that's the other thing about AI and automation. You guys will notice, if you think about your own life experience, I remember when our cell phones were like big bricks. So technology expands very, very quickly. It's almost exponential. So I think that what we're seeing now is a fraction of what the reality will look like in the next 10 years and even more so in 15. So I think we're really close.
Thank you. Okay, so if there are no questions, we'll move to the next speaker.
Yeah, which is actually you. So I'd like to invite Dr. Pascotto up to the podium. He is the head of the Department of General and Minimally Invasive Surgery in Luxembourg. And I guess only within the last year has achieved this accomplishment, so congratulations. But come on up here and tell us about your session.
thank you. Thank you for coming. Thank you for the introduction, and thank you to Luis for the invitation. So I'm gonna talk about does every patient need a robot? Yeah, I work in Luxembourg as head of the Department of General Surgery, and this is my case disclosure. So I still have general surgery. The words are quite weird because I converted from Keynote to PowerNote, so I was a bit disassembled. So metabolic and bariatric surgery is almost the half of my activity, and 100% of revisional cases goes robotically. I still have 30% of my activity laparoscopically, so all my patients need the robot, but they don't have. So this is my disclosure, but I have no conflict of interest for this presentation. So let's talk about what we experience in Luxembourg. This is robot that we use. When we start robotic surgery, it's a very weird feeling. So we start to work far from the patient, far from our assistant, far from the nurse. The communication is very different. We need to work with the feet a lot, with the hands, a console, immersive console. We need to get used with that, because at the beginning we are in a fear zone, because we are uncomfortable doing something that we were very comfortable with laparoscopically. And for that, we need to do robot every week, at least every week. Now, we are lucky I'm doing robotically 2 days per week. Hopefully, I see some people from Intuitive here, hopefully soon, every day. And doing that, we gain coordination. Doing robotic once per month is the best way to never get out of this fear zone, and we'll never get used with robots. So do robot only if you have access to robot every week. And what we developed is this concept of real robotic surgery, which is what my presentation of today will be focused on, which is let's say, a step more forward the full automatization, which is how to limit the most limiting factor that we still have in surgery, which is the human factor, because it's totally unfair for a patient in Luxembourg to be operated so bad when in Badalona it could be operated so good by Jordi Tarasco, and I'm not happy for my patient. But this is the human factor. So when the surgery will be the same everywhere, then we will be talking in a different way. And this is a clear example of what a real robotic surgery is. You can see the surgeon is manning the camera, the graspers. There is no laparoscopic assistance, which doesn't mean that there is no assistance, because we are at least 2 surgeons on the double console working together, interacting, commenting, suggesting the surgery one to the other, but there is no limitation, human limitation to the surgical gesture. So yes, the robot does simplify the anastomosis because it's a sewing machine. It facilitates revisional surgery, super obese patients, and the teaching and learning with the double console is incredibly implemented. But the most interesting advantage of the robot is it's a completely shift of concept from laparoscopic and laparoscopic was, which means many hands leaded by one mind, which is the leading surgeon. And in robotic surgery, you have one end, which is the surgeon maneuvering the console, and many minds around the table working. I don't need to tell you which is more difficult among those 2 pictures. The left is much more difficult, and this is what we do in laparoscopy, and this is what we do in robotics. It's a paradox of coordination in which the surgery that we are doing to our patient, is the result of a coordination of work where there is one person piloting the hands of other people. And in laparoscopy, this paradox is even pushed forward, because even the eyes of the surgeon leader are piloted by another person. And this is like the fulcrum effect in laparoscopy, the fact that the surgeon gets used with that and he learns how to do it. It doesn't mean that it's normal. It doesn't mean a pilot of a plane would never think that it's normal to fly the plane. Then when you go left, you go right, and when you go right, you go left, as we do in laparoscopy. And in robotic surgery, we have the highest levels of coordination nowadays, which is one person moving the instruments and many minds around the table collaborating to the surgery, which is exactly what happened in aviation. We compare a lot of times our job to the aviation because of the security matters. In aviation, you have a pilot flying and a pilot monitoring. They never pilot together. There is always one flying and one monitoring the other one. And pilot flying, as you can see in the first part, pilot flying and pilot monitoring have nothing to do with captain and first officer, which means that in a really respect vibe of work, the lower in terms of grade can say to the higher, look, it's not that way, it's the other one. And this is what we do in our OR. For that, you need a lot of respect in your team. And this concept has been published last week in the Journal of Society of Laparoscopy and Robotic Surgeon. So what is true that we have a new way to communicate in robotic surgery, and this is something that you also need to learn because that can bring you to errors. And that's because in laparotomic and laparoscopic surgery, we are close. We watch all of us the same things, the patient or the screen. And in robotic surgery, we are far, we watch different things, and we need to learn how to communicate. And for that, at the beginning, it's very important to listen what the people from the industry says, because they push a lot on this concept, communicate, speak clear. And this is exactly, again, what they do in the aviation system. And that's how we do that, again, doing robotic every week, because we became a robotic team, not only robotic surgeons. So when I arrived in Luxembourg in bariatric and metabolic surgery, they used to do fast-track protocol, which means patient discharged first to postoperative day, no intravenous perfusion, and no drain, no nasogastric tube. And in 2018, when we started robotic surgery, we had more or less 600 patients in our fast-track protocol, and those were our exclusion criteria of the protocol. In 2025, we have more than 1,400 patients under this fast-track protocol, and we have no those criteria of exclusion anymore, except for the bed-controlled diabetes. And regarding the implementation, in laparoscopic, bariatric, and metabolic surgery has been published around 80, 100 procedure. And if you want to achieve a master level in bariatric surgery, even much more, 500 procedure. Here we are in the IFSO Congress. This is the Champions League of Bariatric Surgery. I'm sure that all of you have those numbers, but 500 is a lot. In Europe especially, it's a lot of procedure to achieve this level. In our experience, we compared the experienced surgeon. This is Santi at the left, I'm on the right, and both of us, we achieved the laparoscopic time for a gastric bypass in less than 30 cases. And when in the hospital, you can compare and you can standardize systematize, the procedure, you can reduce the cost. And as we are doing a Roux-en-Y gastric bypass, it's even cheaper than what we were doing laparoscopically. So for all of these reasons, does every patient need a robot? I want to say definitely yes, because again, we are moving, we are reducing the most important limiting factor. We are doing a lot of studies comparing linear stapler with circular stapler, hands-on anastomosis, but why do we do a study comparing a Roux-en-Y gastric bypass in Luxembourg and another one in Berlin? Just because we are surgeons, we don't want to do that. But this is the most limiting factor. Imagine if you were taking a plane, knowing that with that pilot, you have much higher risk to have an accident. And we never discuss about it, but they know that, they have learned that much earlier than us, and that's why there's much more automatization in aviation. So yes, I think that absolutely yes, and I hope that in 20 years from now, I will be invited again in Malaga for the IFSO 2046 to speak about, does every patient need a surgeon? Because I'm not sure about it. And I'm happy to invite you in Luxembourg 8, 9, and 10 of July for the Trucks Congress, where we talk about technology, education, and new robots. Thank you.
So I'd like to invite our audience to come up to the microphone with questions. In the meantime, I will ask you a couple. So thank you for showing me that, or I guess showing all of us that data. I was kind of surprised to see that the cost of the robot could be lower than laparoscopy. I think that is a feat accomplished. Do you think it's important to actually inform the patients about the fact that you're using a robot, and what does that mean, just from an ethical perspective? Like, what kind of conversations are you having with your patients?
That's a good point, because of in my activity, I still have kind of a lot of laparoscopy, I would say, because 25 is too much. In my shared consent, what I signed is minimal invasive procedure. I did minimal invasive sleeve gastrectomy, minimal invasive Roux-en-Y gastric bypass, so I can have the option to change, because I used to do at the beginning robotic gastric bypass, but sometimes for organizational reasons, I don't have the robot that day anymore, and then the anesthesiologist say, I'm not gonna sleep the patient because he signed for a robotic one, so I need to talk with you. So now in the consultation, I explain both options. I'm in a small trouble because I need to be neutral in the consultation, because otherwise the patient will say, okay, I want robotic. So if you don't have that day, then give me another day because I want to go robotic. So I'm still really neutral when I do the consultation with the patient. But personally, first of all, I really suffer when I do a laparoscopic gastric bypass, not because of the shoulder, not because of the position, because of the interaction, much more. My assistant is more focusing about how I need to take the grasper, because I told him, keep it that way, and it's not reflectioning with him in the surgery. It's not a useful mind next to me in that moment. It's a useless mind, because it's just focused on, I work mainly with residents. I don't have a 20-year surgeon next to me operating with me, which is great. I love to work with residents. They are brilliant and they are full of ideas, but if you keep them stuck on keep it that way, first of all, that way will never be the way you really want to, because it's just not yourself, it's another person. And second, is just focusing on that. I've been assistant in robotic surgery because I was there when my boss started his learning curve, and I never felt so useful as I felt in robotic surgery as assistant, as I didn't have a grasper anymore. I was just there operating with him, really operating with him. But for that, again, you really need to have a respectful relationship with the other person, because if you have a first-year postgraduate at bedside assistant saying a comment, you need to take careful the comment. You need to, like, everybody need to feel part of the surgery, and not like it's one-man stand and the other are just there, but if they're not there, it's fine.
Okay, thank you.
Thank you.
So we'll move on to the next talk.
Yeah, I'm happy to present Professor Giuseppe Navarra from Italy, former past president of Italian Society of Bariatric and Metabolic Surgery. We'll talk about economic impact and sustainability of robotic bariatric surgery. Thank you, Giuseppe.
Okay, thank you. Thank you very much for this kind invitation. After having put both feet in the future, we are back in the present, looking at the past. So I organized this speech like a PICO. So we are talking about bariatric patients, comparing robotic bariatric surgery with laparoscopic bariatric surgery in terms of cost and sustainability. We know the difference between the two kinds of surgeries, and to just introduce the topic, I want to show you this report published a few months ago by the Ministry of Health and the agency that oversee the NHS, showing the cost effectiveness of robotic surgery, analyzing 11 operations in the field of general surgery, and only 2 of them, esophageectomy and total gastrectomy, are cost effective. But I use this report to show you how the trend of robotic surgery in Italy is going up, and especially in university hospital and research hospital. At the end of 2024, there were more than 200 Da Vincis, 18 Yugos and 10 Versus. And going back into the main topic, this is the picture of robotic bariatric surgery around the globe through the 9th Global Registry report. In the US, there are more than 36% in 2023 of primary bariatric surgery performed robotically and more than 41% revisional. This is the experience in Italy through the data coming from the registry of our national society. There is a steep increase, but the numbers are still low, knowing that only 344 robotic cases were performed in 2024 out of more than 28,000 procedures. The data that I will show you are regards Da Vinci platforms, and in the next few years we will see data coming from all the other platforms. And I start from this systematic review and meta-analysis that shows how robotic surgery is more expensive, or around $4,000. This is, if we look at total hospital cost, regardless of the kind of procedure. Operating room cost favors laparoscopy, overall operative time favors laparoscopy, while post-operative complications are almost neutral. But how can we reduce at the moment, today, cost? We can focus on subgroups of patients, or we can focus on surgeons-driven variables. What about patients with BMI over 60? We think that clinical outcomes should be better, but there is no evidence of this, even if there has been a rapid adoption of robotic technology on these subgroups of patients, probably just because of economic benefits, enhanced visualization, and improved dexterity. And we know that even in this subgroup of patients, costs are higher, as shown by the Catholic University in Rome group led by Marco Raffaelli. What we have noticed, I think around the globe, maybe a bit less in Italy than in other countries, that there has been a reduction in prices of disposable that we need in robotic surgery. And if we put together the reduction in cost, the fact that maybe, as shown in this paper, bleeding or some post-operative complications are a little bit higher in laparoscopic surgery, we can achieve costs that are not statistically different in complex cases, as duodenal switch as shown in this paper. If we look a little bit back a few years ago from a group in Turin, there was already something there about reduction in cost, as shown in the graph in top left. And then analyzing what was the break-even to make cost-effective robotic surgery, we should have more than 13% of leak rate in laparoscopic surgery, more than 14% reoperation, or a reduction of 12% in robotic cost. This is another paper, interesting paper, dated 2012, that shows how robotic surgery is or was cost-effective if the leak rate of laparoscopic bariatric surgeries was more than 2%, if there were less than 10 cases per week, and if the operative time was shorter than 30 minutes robotic compared to laparoscopy. What about the surgeon-driven variables? First, learning curve. Learning curve in robotic surgery is steeper, but moreover, morbidity during learning curve for fellows and residents compared to the senior is higher in laparoscopy and equal in robotic. With time and experience, operative time goes down, and surgeon can do many things in the OR to save money. One of these is avoid some more expensive energy device or advanced energy device like the vessel sealer, or can use bedside stapler. Obviously, these are blasphemies for orthodox, but if you are constrained by cost and by the general manager of the hospital knocking at your door, you need to think about ways of saving money. And this is a really good way, because avoid make a saving of more than $1,000 per procedure. How this saving come from? The cost of the device, the reduction in operative time, and maybe a reduction in bleeding, post-operative bleeding. And there are many papers published that confirm this. But what about the poor surgeon? Poor surgeon has a problem of durability himself or herself. And so we know that there are musculoskeletal problems, injuries, more often in laparoscopic surgeon than robotic surgeon. And this is a elegant paper that shows how the strain on musculoskeletal muscles and structures is much higher after during laparoscopic surgery. And we can measure objectively fatigue with EMG, and we can show that this is real. It's not just a matter of sensation, of complaint about the surgeon. But something more interesting is that the diminishing need to control posture in robotic surgery removes the competition for cognitive resources, allowing surgeons to focus on the surgical task, but ultimately reducing cognitive burden. And then there is all the matrix that we need to take into account that improve and make procedures more safer. So robotic bariatric surgery is currently more expensive compared to laparoscopic approach. It should be integrated in multidisciplinary robotic programs, and hospitals should calculate break-even point per each robot. There is a need for experienced team, standardized OR time, and low complication rate, and the value is maximized, as has been said previously, in revisional surgeries and complex primary surgeries. What about sustainability? I didn't find any specific paper on bariatric surgery, but what we can tell from this one is that there is an increase in production of disposable, and there is, for example, in case of hysterectomy, more than 2.5 kilos of waste more in robotic surgery than laparoscopic surgery. And this has been proven and confirmed even by this paper. And more interesting, recent life cycle assessment revealed robotic system draw approximately 3.5 kilowatt during operation, generating roughly 4 kilos CO2 per hour compared to 0.6 kilowatt and 1 kilo of CO2 per hour for conventional laparoscopic equipment. And then there is also a significant waste burden. Multi-specialty audits demonstrate that single-use items account for 93.9% of robotic case waste by weight, with components such as instrument arm drapes contributing up to 32.9% of total per case waste. So there is a call to manufacturer and a call even to health professionals to take regular waste audits that can identify items often for unused, excessive packaging, and opportunity for standardized preference card optimization. And so in conclusion, the widespread use of robotics in bariatric surgery is still controversial due to the lack of evidence showing improved clinical outcomes and the higher cost compared to other treatment modalities. Thank you very much.
Thank you. Thank you, Pippa. Are there any questions from the audience?
Thank you. That was a phenomenal talk. I think you have tons of evidence that we can take back to our hospital systems to demonstrate the benefits of robotic surgery. But I think currently the robotic platform is still a limited resource. How do you think hospitals should decide which cases get robotic time? I know it's kind of a controversial question, but that's my first one for you, and I have a second one after that.
Urology is pulling everything.
Yeah.
So if you have a strong urology, you have the robot. If you are by yourself, you have nothing, because it's impossible to justify, at least in the Italian system and the volume of each hospital, justify one robot for one specialty. So you need to work in teams, and urology is pulling the weight. In in Italy, there are quite a lot of platforms available. Just in Sicily, where I live, there are 5 million people. There are at least 10 robotic platforms. So it's not a problem of availability. Probably is a problem of giving the right indication for the right patient, right pathology and the right patient. Obviously, there are not enough robots to do everything in every single specialty, but there are platforms. And then I'm quite an old laparoscopic surgeon, and laparoscopic instruments are part of my arms. So my case mix is 80% laparoscopic and 20% robotics. But probably the bias is that I started 40 years ago. And so for me, I don't say that it's much easier doing it laparoscopically because I recognize the value of robot, but I don't know how much you need to, for the robotic platform to translate the definition, the precision in clinical benefit. This is my main concern. It's wonderful to work at the console. It's for surgeons like anatomy. And so when you sit down and you look inside, the anatomy is wonderful. But I don't know, even the gestures are much more elegant, but I don't really know how much of this translates in clinical advantage and benefit for the patient in which procedure.
Interesting. So I think as you mentioned, there are multiple platforms, and I pointed out in my earlier talk that lots of companies are now coming out with new versions of their robot. So I imagine over time the cost will reduce. But what effect do you think that will have on the efficiency if you're running multiple systems?
I think the biggest driver at the moment is cost. Everyone wants a fancy car, but if you don't have money, you can watch it on the movies or on TV. Once you have enough money or the car is available for more, everyone wants to jump on. There are advantages not with the platform now, but for sure with the newer generation platforms, there will be huge advantages and you can't stay out. Okay. It's something in progress.
I want to make a question. We started the day talking about the future is green, talking about sustainability and environmental aspects. Do you think robotic surgery is much clean than laparoscopic, generate less waste than laparoscopic?
So this morning I listened to a presentation that was really, really nice. And what I saw that you need to help the planet. Seems a general affirmation, but it's not. So if you dispose all the garbage and you dispose it in a green way, you can recycle a lot, really, really a lot. So there is more waste, but if you recycle, there is no problem. And then something no one is making really attention on is that every complication has also sustainability issues, because to treat and solve a complication, you need energy, you need material, you need time, you need water, you need lots of things. So even reducing complication is loving your planet and saving money and being more sustainable.
Okay, thank you.
Thank
Any
you.
other questions? Thank you very much. Last July, somebody called me on the phone saying you are going to live for the first time an experience in Spain. I say, Dr. Tarasco, he was calling me, what's the matter? So somebody is going to operate, Dr. Norberto Casinello in Valencia. He's finishing his proctoring training in robotic surgery, and he's the proctor of Dr. Casinello. And I'm going to be the guest from Malaga. I'm not sure because I am here because we are friends, because the Congress of Malaga doesn't matter. It was an amazing experience. And today, Dr. Tarasco from Badalona is going to talk about remote proctoring, how to teach robotics.
Hello, good morning. Good morning, everyone. First of all, I would like to give my thanks to the organization for this kind of invitation. It's a very pleasure for me, and I hope to enjoy my presentation. Well, today we will talk about how to teach robotic surgery from a distance, remotely. My name is Jordi Tarascó. I'm a bariatric and endocrine consultant surgeon at the Germán Stegi Pujol University Hospital in Barcelona, and these are my disclosures. Well, when we talk about remote interaction in robotic surgery, we actually referring to several different concepts. This includes telesurgery, remote proctoring, telementoring, and telecollaboration. But only 3 of them involve remote interaction between a local surgeon and a remote expert, all in an educational or training scenario, okay? The main difference is the level of the remote expert participation. Let me explain. In a remote proctoring, I evaluate you. In a telementoring, I teach you. In a telecollaboration, I assist you. By comparing these 3 modalities, we can say remote proctoring is mainly for evaluation, not teaching. And it can be done in a real time or through a video review. Regarding the telementoring and telecollaboration, often overlap, and the key difference lies in intent and context. Teaching versus assistant, learning curve versus complex cases. But these 2 concepts are dynamics and must be in a real time, of course. But in other words, the telementoring sessions can quickly evolve to telecollaboration when complications arise or when expert decision-making becomes critical from distance. Finally, today, the remote expert can connect to the local surgeon in a real time through different technological tools, allowing several levels of interactions and support. The remote expert can use surgeon console, personal computer or laptop, and why not? Today it's possible to use VR, MR headsets, virtual reality or mixed reality headsets. And an ideal and plenty remote robotic training using a surgeon console is at this moment, yes, the best option. This enables telementoring, telecollaboration in complex cases, as mentioned before, and potentially even telesurgery. The most important advantage is the takeover capability, enhancing safety and allowing the true hands-on training, something other technologies cannot offer. However, there are some limitations related with the surgeon console, as you know, cost, platform, hospitals, dependency, and if you only have one console, you are going to block your operation room. The takeover capability is not yet available when you use a VR or MR headset, but I think we are not far from that. Maybe it's a science fiction, maybe. Here's the 3rd generation of the India robotic platform, Mantra 3, where the surgeon console uses AR glasses to perform the procedure without a screen. Come back to the modalities, and regarding the remote proctoring, I think that using a surgeon console in this situation, in a remote proctoring, maybe is a bit excessive. Using a personal computer or laptop is still most convenient and cost-effective option. But immersive technology may have unexpected benefits. When I'm requested to evaluate recorded videos and I use a 2D screen, I find some difficult to check if the trainee has a proper depth perception. Maybe the 3D view could help to refine our evaluation. So respecting the telementoring and the telecollaboration, the personal computer-based solutions are more accessible and scalable because they can be used anywhere and are also platform independent. Immersive technology might represent the present, the future, offer the 3D immersive view, and the true telepresence. Let me show you the potential, okay, and the potential of the VR, MR headsets compared to the personal computer as a training tools in a telementoring or telecollaboration. As you know, Intuitive offers a digital solution. It's for DB5. It's called My Intuitive Plus. It's enabled to remote the telementoring and will soon support a telecollaboration. However, it's still limited. The dual camera setup and fixed OR view reduce awareness of the environment, and the 2D image decrease the immersion and the sense of the depth. It feels more like a remote viewing than a true telepresence. M-Surgery is a Spanish company from here, from Malaga, that has created a universal digital platform independent of any robotic platform, and it's a one solution for all platforms. You can use computer for remote connection, but the best experience and what makes it unique is when you combine it with a VR, MR headsets. Here is an overview how the 3 cameras in OR allows to you to set up the dynamic grid for auditorium and users. Years ago, we performed the first telementoring procedure in Spain using M-Surgery to validate this technology with Dr. Norberto Casinello, Dr. Luis Ocaña. Dr. Luis Ocaña and I use an Apple Vision Pro to enhance the remote experience. You can observe the configurable grid view and camera setup used during a sleep and gastrectomy procedure. The use of VR, MR headsets with M-Surgery allows the remote expert to have the same 3D immersive view like a local surgeon console, okay? And to have the real telepresence with the 360-degree cameras. And moreover, it's possible to perform the illustrations, annotations. Finally, okay, let me show you how we use a technology in a pilot test, okay? It's an emergency surgery. The case was acute appendicitis. It's not spectacular, okay? But it's allow us to validate and safety and feasibility the technology in this scenario.
Perfecto, no te preocupes, dame 5 minutos y me conecto.
Hola Ingrid, ¿qué tal? Estoy conectado ya. Pon la visión del Tile Pro y que me veas y me explicas un poco el paciente, que me comentabas por teléfono que tenías problemas técnicos de dificultad de movimiento de brazos.
Sí, mira, es un chico de 33 años con una apendicitis aguda de 24 horas de evolución, 19.000 leucos y tiene un índice de masa corporal de 40.
Pues hacemos una cosa, haré una visión 360 del quirófano y del robot, a ver si externamente veo algo raro. Perfecto, ahora veo todo el quirófano, Ingrid.
¿Vale?
Vale, habéis hecho una entrada lateral, veo, entrada lateral.
Sí. Vale.
El primer asistente tiene que coger el brazo robótico y traccionar físicamente para crear como más campanas. Haciendo esta maniobra de los 3 trócares tendrás mejor visión, mejor maniobrabilidad, incluso tendrás mejor exposición.
Vale, pues lo probamos.
Vale.
Aquí. Y así también nos digamos un poco el camino.
Vale, ¿puedes poner un segundo el Tile Pro para que pueda hacer anotaciones?
Sí.
Entonces, harás todo esto, Ingrid.
Exacto, esta es la idea.
Correcto. aquí. Perfecto. Yo ya me desconecto, ¿vale?
Vale, perfecto, gracias.
Well, only the first experience, okay? Take home message, remote robotic training is not about distance, it's about control, communication, and safety. Remote mentoring or telecollaboration with takeover capability is the true surgical training, okay? Immersive technology offers an improvement in a remote telementoring and telecollaboration compared to use of personal computers or laptop. Thank you very much.
Any question from the audience?
Are you still going to the hospital or you always work from your living room? There is a question.
Okay.
Yeah.
Please, Roberto.
Thank you, please. As they have said, I was the surgeon on console that day we made that pilot. And we had a major intraoperative bleeding complication that is not shown in that video. But that day I was so lucky to be helped by Dr. Ocaña and Dr. Tarasco that was settled more than 500 kilometers away from my hospital. So my point is, think about this. Dr. Pascotto said that robotic surgery is solo surgery. I agree, until you have complications. When you deal with complications, you don't want to be alone. You need help. And for example, next week you are going back to your countries, and maybe on next Tuesday you have a reduced surgery or a super obesity surgery. How many of you, or how much would you like to be helped by one of those experts that here present? That's my opinion. Thank you, Jordi.
Yeah, just to comment, my point was exactly that you're not solo. You're like, there is one person moving the instrument, but there are a lot of them around the patient that are cooperating to the surgery. I agree with you that you don't want to feel alone. I totally agree with that. Not only when you have a complication, even when you're enjoying a nice surgery, you don't want to share it with your colleagues.
Jordi, I am very lucky. See these things doing here in Spain is amazing, because I think this is the future, maybe the present, in your case in Badalona. But you think it's easy to put this program working, to have an robotic surgeon on call anytime? It's very complicated. And how about the responsibility after the surgery? Is the robotic localized surgeon virtual reality is going to in the surgical report? No sé. There are many questions to ask.
Yeah. It is the future, okay? I think how many times, and with you are young, no? with intra-operative problem, with a laparoscopic approach, a colleague of you with a video call send an image no? to perform the procedure and try to show with a colleague with more experience and try to help you only to using a smartphone, for example. I think it's a new opportunity. With it's possible to perform the robotic procedure in emergency room, and in the future they use these new technologies. I think the closed platform is very related with immersive technology.
I absolutely agree with you. When I was a resident, we have an internal hernia in a young woman. We make an scopinaro.
Yeah.
Very big problem. We have to remove maybe 2 meters of small bowel. And I removed my gloves, and I told to Dr. Rivas, he's our boss, and everybody was talking about, okay, you're not finishing the patient. Let me 5 minutes, let me make a call, because we are starting making bariatric surgery. It was 30 years ago. I was so young and so inexpert. And in 2 minutes, Dr. Rivas explained me what I have to do.
Yeah.
Try to remove this, obviously, necrotic tissue, but try the patient go outside the surgical theater with a bariatric procedure, because she's still in the process to losing weight. So that's the reason I go back to the surgical theater, and I was another surgeon with more skills. I think this you are doing to your residents from your home with virtual reality.
Thank you.
Thank you, Jordi. It's also my pleasure to present to you the Chief of Department of Germán Trias y Pujol, Department of Surgery, Dr. José Balibrea. He's going to talk about summary discussion, robotics in MBS, standard or luxury.
Okay, or no? Yes, it's okay. So, first of all, here we go. Yes. Well, first of all, I would like to ask for a big hand for the technical support because it was kind of difficult. So thank you, guys. Thank you for the kind invitation. I'm José Balibrea. I'm the head of the Department of Surgery in Germán Trias y Pujol in Barcelona. And this is the key message. So after so many talks, the question is robotic surgery in metabolic and bariatric surgery remains non-standard. It's just a luxury, something that you just ask for, something that you use just for fun, is something that you must use because of FOMO, fear of missing out. So that's something that happens. It's something that happens because you're under some kind of algorithm capitalism because there are some way of managing you and your choices in the OR. Well, let's have a look. So first of all, these are my conflicts of interest. The most important is, of course, I always use some AI tools for my presentations. And if you want, you can scan this code because I have some papers for you that can be useful in order to check the usefulness of the robotic surgery, some about health economics. It will drive you to my drive. I will get you access after I finish the talk. So the most important thing is the first question, and the most important question is that maybe is to answer whether if robotic surgery is a luxury, maybe we are evaluating a situation in which the market is very complex. So are we evaluating robotic surgery or are we evaluating the market? Okay? Health costs are rising, and maybe you can say that they are unsustainable in a huge unsustainable rate. However, surgery alone is about 1/3 of the whole total spending of a hospital. The second question is, okay, this is quite uncomfortable because maybe the question is if we are evaluating robotic surgery or what I call turbo laparoscopy. What does it mean? I mean, robotic surgery is a completely different concept. It's what Professor Azagra always comments is robotic mindset. You work closer. You can do a gastric bypass only with the hook because you change some maneuvers because you do surgery in another way. If you're performing laparoscopic surgery with a robot, you are doing turbo laparoscopy. So completely different concepts, okay? So you can see it. We are rising healthcare costs, and of course, we need what we call value-based care. That's undeniable. As I mentioned, surgery is about 1/3 of healthcare expenditure in a hospital, in a public or private system. And we have to take into account that the blast about the expansion of robotic surgery across the specialties, not only metabolic and bariatric surgery. So does robotic surgery justify its costs? I think so, but the key question is robotic surgery a worthwhile investment or just simply a luxury? So we have to take into account the structure of the costs in surgery. Sorry, because now I became some kind of manager. I'm kind of obsessed with those concepts, but I think they are interesting for comment. So the direct costs, the equipment, the material, the time, the OR time are so important. But the indirect costs, especially in this particular case. So the capital investment as well as the maintenance. You have to keep the machine going and working for you. So when you're talking about the specific costs of a robot, you have to take into account that the acquisition will be $2 million or euros, and it's higher nowadays. The cost per case nowadays we cannot deny it. It's higher. However, it's about the instruments. It's about the time. No, The major cost drivers are the OR time, but the clinical results. That's the difference between turbolaparoscopy and robotic surgery, because they don't have the same results, okay? So when talking about the outcomes in robotic, metabolic, and bariatric surgery, clearly, nowadays, they are comparable. And I have to be humble, because I don't want to convince you. They are comparable to laparoscopy in many, many cases. However, we have no significant difference in comparison to laparoscopy in terms of mortality or complications. That's key. Some advantages, only for Roux-en-Y gastric bypass, at least at this moment, with the evidence-based medicine whatsoever. Lower readmission rates, lower complication rates in revisional surgery. That's what we have nowadays. Trade-offs. No, you can look as many papers as you want, longer operative times in most of the surgeons. However, if we have a critical look at the evidence, okay? First of all, most of the papers are case series or quality registries, not focused in health economics. There's a clear effect about the real world against in my hands, in your hands, in their hands. So it depends on your experience. It depends on the volume of your institution. It depends the use they do. You are using just for metabolic and bariatric surgery, or you're doing any type of surgery. That's important. Most of the time, when you take a look at the literature, you see papers that the range is from 2010 to 2024. There are a coexistence of very different robots in those papers that are not comparable. The first generation of Da Vinci is not comparable to the Da Vinci 5 whatsoever. It's not comparable. Many linear curves, many surgeons coexisting. And forget about that. The robotic assisted is an old concept. We have to switch into totally robotic, otherwise you're doing, again, turbo laparoscopy is completely different. And finally, most of the times you don't find the proportion of robotic cases in those papers. You don't find them. You don't find them. So there's something that, from my opinion, well, you have to take a look with some criticism on the available literature. So let's talk about the money, because it's different. When you talk about money, you have to talk about the cost allocation. You have to identify which kind of costs are you talking about, to measure it and to evaluate, because the context, again, is key. It's different, the micro or macro costs, and the most important part is the kind of analysis that you do. If you do what they call top-down analysis, I mean, per process, you are saying an amount of money of the process. Robotic surgery will be, so expensive. However, if you have a look bottom up, if you go into the detail and you register every single case, every single instrument, you will find that it's worthy to invest in a robot. About the cost effectiveness and efficiency, nowadays we know that the robotic surgery at these days is more expensive. Sleeve gastrectomy, maybe $1,050 higher, revisional cases for gastric bypass, but if you go to the broader surgical data, it's about 25% higher. Well, it depends. We have to interpret the economic value. So you have to be familiar with some concepts like the ICER, is the incremental cost. So in some cases, when you look at for example, robotic surgery in the gastric bypass, the ICER is acceptable. It's below the willingness to pay. But laparoscopy nowadays remains most effective in most base scenarios. The most common patient maybe is better, but robotic has become cost effective when complication rates, it has been mentioned before, are higher than in laparoscopic, on when the cost of the robotic platforms will decrease, okay? I'm not going to convince you, but when my manager asks me, why are you using the damn robot for bariatric cases? I can give you 3 reasons. First of all, you are creating a space. This is a very complex patient with a ventral hernia, 60 BMI, you can do abdominal wall lifting. You have better view than laparoscopy. You're going to have more space. You're going to be able to perform difficult maneuvers easily. Second, you're avoiding the fulcrum effect. You're improving your ergonomics. You get less pain. You can operate more cases. That's good for your manager. You can talk them. And finally, it minimizes the BMI effect and clearly reduces the degree of complexity in revisional cases. These are my 3 key questions. So, to be honest, first, when I think that robotics add value, when you have complex and revisional bariatric surgery, because the lower complications rate can justify the investment and the cost. Second, if you have a robot, use it. The worst thing that you can do is to have a robot and do not use it. So high volume centers, the cost can be spread over the cases. Surgeon ergonomics is important. It's very important because we have to keep, now we have a shortage of surgeons. Now these days, the Spanish students are choosing which specialty. No one is about to take general surgery because it's so hard. So we have to take care of ourselves. So we have to maintain the workforce. It's about the long-term workforce sustainability. Finally, potential system-level benefits. If you reduce complications, you're going to have lower downstream costs, clearly. But again, to be honest, when I think that robotics is a luxury, if you perform in a routinely manner, if you perform routine bariatric procedures, primary sleeve, no clear clinical advantage, higher costs may be unjustified, unless you're working in a very, very high volume institution. Of course, if you're in a limited resource setting, this is not worthy. You have to take care about the rest of the company, the rest of the hospital, the rest of the department. However, we have another problem. If you have marginal improvements in outcomes despite the large cost increase, that depends mostly on the volume. And some procedures, remember, like the elective but not emergent robotic cholecystectomy, at the end of the day, don't have an ICR balance or threshold. So, in order to be concluding the system-level considerations, the efficiency matters, okay? However, maybe robotic surgery is saving a lot of money because the learning curve is completely different, because the learning pathway is completely different. We have to standardize, and the best way to standardize and to democratize accessibility is robotic surgery. That's why we are trying to avoid some equity concerns about the access of robotic surgery. Yeah, it will be a problem in the future, but nowadays I can tell you that if you have a robot, you're offering your population a better treatment. So this is a classic. This is from Eric Topol's Deep Medicine. Remember, by this year, the most interesting part of applying AI in medicine is robotics, because it's the best way to apply AI. The first lecture was brilliant about that. And remember that the higher the cost of the complication, the most worthy the investment end. And finally, I'm about to end, trends and key factors. When the ecosystem will change, we will have more platforms, it will improve. When you choose a platform that is able to give you multi-quadrant with the staplers, with energy. Do not invest in those platforms that are not ready. You are able to standardize your technical aspects, and you are avoiding two-step procedures, so that saves a lot of money. And finally, take care about the training, take care about your team, and about how you implement this technology. But the most important part is, remember, it has been said, data collection and the use of AI through the robot will save a lot of money. So that's why I think this is worth the investment. So if you ask me, do you think that the future is robotic? And I say, yes, and any kind of resistance will be futile. Thank you so much.
Please, question?
Yeah, thank Thank you for this talk. I really like I really like your example about the case with BMI 60 and incisional midline hernia. I would just like to ask two small technical details. Do you think that in this case, using an air seal device would add more space? Because I think on the pictures I haven't recognized this. And second, how would you enter? Because with laparoscopy we would do an optic view entry and we were very careful, we would expect a lot of adhesions. But with the robot it's not so easy to apply optic view entry. So what's your strategy in this situation?
The first question is the easy one. We don't use any kind of air seal, or we use the wall lifting maneuver, something that Dr. Tarasco told me. You know, I started doing turbolaparoscopy many years ago, 2013. Thanks to him, I'm doing robotic surgery. And the second one is that we always, and please don't kill me, we use the Verus needle instead of any kind of other. We always use the Verus needle.
And then blind entry, which is, I think, of course, most of cases for a virgin abdomen is perfect, but in this situation it might be a bit risky.
Our experience, if you put it in the Palmer's point, you know, in the upper left quadrant.
But I mean,
but I have to admit, I have had some problems, at least one. I remember some embolism because there was a huge liver, which I had a problem, to be honest. I mean, this is not Walt Disney picture. That happens.
Excellent talk. I just have a question about your comment saying that the simpler cases, the robotic cholecystectomy, the straightforward sleeve, I mean, I'm totally on your side with this, but I'm playing devil's advocate here. Do you see any benefit of doing those types of cases on the robot while you're in your learning curve?
Absolutely. I mean, my personal opinion is that it's worth it to perform a robotic cholecystectomy, even an elective one, because you're learning better. But the guys from Portsmouth in the UK, they're using a 3-arm approach. We have the acute care program, and we are seeing the clear benefit, clinical as well as economic benefit. But the key question is, how are we going to teach our residents? Because maybe you will have to become a 21st century surgeon, you will have to do 3 learning curves: the open, the laparoscopic, and the robotic. Is there time enough to do that? Are we able to train our next generation of surgeons with this kind of situation? I don't know. My honest answers would be, I don't know.
We have 10 more minutes, so we can make questions to Dr. Balibrea, also Dr. Julian Joy, and also Benji Pascotto and Dr. Tarasco. I want to make you a question, Jose. You are now our head of department, and
unfortunately,
you can see now in the hospital, you know, a different kind of surgeons, surgeon robotics and surgeon no robotics. It's very uncomfortable, especially for people we are trying to do robotic approach and we cannot do it because we have no hole in the surgical theater where the robotic is. Imagine you are going to a hospital, nobody is making a robotic surgery, and you have a platform. You prioritize one unit against others, or how will you do everybody to access to the robotic approach?
Excellent question. First of all, if I arrive to a hospital, the very first thing that I will do is to work a lot. Do not be in a rush about starting any kind of problem. Work with nurses, OR techs, and anesthesiologists. That will be my very first target. If you convince that environment, that ecosystem, then you can start talking to the surgeons. Otherwise, you're going to fail. That's what I did with the emergency program. I started with nurses and OR technicians. After that, you have to find those programs or those procedures that can be standardized. That's why I think that bariatric surgery is a very good example, because thanks to the standardization now, laparoscopic bariatric surgery is a safe thing, it's a very safe procedure. Do not go into the esophagectomy at the very beginning. Do not jump into pancreatic surgery. Besides, I think that laparoscopic pancreatic surgery is dead because it has to be done or open or either robotic or open. But choose very carefully which procedures. Look about, you have to know your team and identify which one is the better doing what. So if you have a very solid program that everything is standardized, I don't care, maybe it's abdominal wall. It depends on your institution, but my advice would be work with the nurses, with the OR technicians, with the anesthesiologists, and then choose some program that is very well established and standardized in your hospital, and then start with that program, no matter what. Maybe it's colorectal cancer, I don't know. But bariatric surgery, time to time, is very well standardized.
I have a question at you, Jose, maybe you others, you can also give an answer. I know many American surgeons who have access to robots every day, so they think, I don't want to change from laparoscopy to robot, because it's there, and I don't want to change my thinking and my ergonomics all the time. But actually, most of us here, they don't have robots available all the time, so I select cases that I do on the robot. Is that a concept you're critical about this concept because you don't think you should do the difficult cases with the robot, but there's some things you have to do through the hiatus where I think the robot is so much superior than to do it by laparoscopy because you don't have all the range of motion. So you do like a large hiatal hernia, a large pouch herniation or whatever, to revise esophagojejunostomy that's moved up to the heart. I mean, you can go there. So what is your advice for people who do not have access? So is it only one surgeon doing or two surgeons, then they train them? And the second question is, you will not be able to have the young surgeons go into open surgery, laparoscopy surgery, and robotics. So where are they going to convert to if they have an issue? Is it going to laparoscopy or is it going to open surgery?
Depending on the, thank you so much, Ralph, for your questions. The second one is easier in terms that I think that they are going to go for open. They are not going to switch to laparoscopy. If you have a problem in robotic surgery, I think that they will switch to open, the conversion, but that's a personal opinion. And the very first question, that is the hard one, is you have to know your system, you have to know your institution. So it will be desirable that everyone gets trained. But nowadays, this is not possible because the training is not on our hands, not in the institutions, not in the scientific societies. We are not on charge of the robotic surgery training. We have to admit that. So if you only have one platform, if you have to select a program and you're starting, I will select 2, 3 surgeons. That is completely against democracy, but sometimes the system cannot be democratic. However, we have a strong bias because in our department we needed that 80% of the surgeons should be certified in order to start the emergency program. But that's a huge bias and depends. We have 5 platforms, which is not so common. But if I only have one platform, I will have to choose 2, 3 surgeons to do a particular program. And then when you have that program very well established, then switch to another one. But step by step, you cannot rush. I mean, otherwise, the implementation is different between institutions. But something that you need kind of lean methodology for every single institution is something that you have to pay attention and you have to spend a lot of time because it depends on the institution. There's not universal implementation scheme for every single institution. You have to make your own, tailored suite for every single institution.
Yeah, if I can comment on that, I totally agree with you, Jose. You need to find few persons that have access to the person that are going to be taught in robotic surgery, they have to have access to the robot every week. They need to be able to perform robotic surgery routinely. So if you have in the department 15 surgeons, it would be just impossible with one platform. So how to choose? That's a very hard question because I say quite difficult, especially if you have more specialties. In our hospital, we had this problem, for example, with thoracic surgery because the thoracic surgeon decided to start when all the other specialties already, he had access since the beginning, but he didn't want. And 3 years later, the robot was full. So he started to have access once per month, and he did 3-4 months some procedure, and he stopped, he never do it again, because he was struggling every time. And then he saw 6 months after he was still struggling, he said, okay, leave it. So this is like, you will pass a gap, especially if you have already experienced surgeon and you need to do a step back. Because if you, during the residency you were teach to both laparoscopic and robotic, then you just keep on doing both. But if you need to do a step back and you are an expert laparoscopic surgeon and you need to move to robotic, you will feel bad at the beginning, really bad. So first of all, it's a huge touch for your ego. Like you start struggling doing something that you're really good doing laparoscopically, and there is an industry person next to you telling you how you should do that. And sometimes there is a proctor that could be even younger than you that say, look, for the gastric bypass that you have a huge experience within laparoscopy. Look, it's not that way, it's the other way. It's very, very touchful for the ego. So that's why I think that for young surgeons, it's easier. And for the experienced laparoscopic old surgeon, at least what I see around the world, there is this barrier, among others, which is the ego to move to someone that you need to do a step back to go far after.
I don't know, I'm going to push back on that a little bit. So I think it depends on the perspective. So obviously if you are in a leadership position, if you're like the head of the department, then I think this is probably the better approach to find someone who is going to be more pliable, more open. But that doesn't mean that a senior surgeon, or maybe I should say a more experienced surgeon, who has an interest in adapting this into their practice can't do it. I think I agree you have to have regular touches on the robot, and the recommendation is at least once a week. So going from having a vibrant laparoscopic practice and then saving the robot for the complex cases, I think is not going to be as beneficial to your robotic experience as if you do more simple cases like more frequently. That's just the reality of it. But it doesn't mean that you can't do it the way that you're proposing. I think it helps to have someone on hand to assist, to provide some feedback like a proctor, like you just mentioned. But you also do have to stay open-minded. I think it's possible.
Yeah.
I wouldn't say no.
Absolutely. I will just add that no one of us is what we call digital native. The kids that are coming, they won't need any training because they sit in the console. We allow our residents to perform some procedures. They sit in the cockpit and they know exactly what to do. As Dr. Pascotto said, you spend months learning how to put the stitch, how to switch the pedals, and then some awful kid goes to the OR and then sits there, is able to do whatever he or she wants. But that's miserable for us, but we had to admit it. In 10 years, they will be leading our surgery instead of their capability to understand the digital transformation of surgery is wider than ours, for sure. So it's something that it doesn't matter because I'm sure that the digital natives will learn faster and surgery will be better thanks to them. However, as Dr. Petelli said, when they have a problem, they will have to open the patient and they will say, wow, it's alive.
Actually, just a quick comment about your second question. So I think the conversion that you go to should be the one that you're more comfortable with. So if you learned in an era of open surgery and that's what you feel comfortable, then you should convert to open. If you learn in an era of laparoscopy and that's what you feel comfortable, I think it's fine to go from robotic to laparoscopy. Unless, of course, there is a more urgent issue happening with the patient, like bleeding, and you just feel like you can't control it, then of course open instead.
Okay.
Okay, sorry.
No, I
sorry.
think we can close. Now I'm going to close the session.
Okay. Well, I remember Dr. Amino Ramos in Belviche talked to me about two younger, very young surgeons in Brazil making a Roux-en-Y gastric bypass, and they have a tremendous bleeding. So they decided to convert with transfusion and the patient in the position, trying to increase the blood pressure. They converted to open surgery, and they start trying to fix in open surgery. They cannot do it. So they convert again to laparoscopic approach, and they fix it. So that's the reason it's very important. You are talking about our young surgeons, they are going to learn directly robotic surgery. So they have to compare to laparoscopic to open. When I talk to my resident during the time we are on call, I recommend them to try to learn open surgery. If we have to do, for some reason, open surgery, don't go away from the operating room. Try to see everything. Okay, we have to close this session. Thank you very much, Julian. Thank you, Benji.
Thank you to
Thank you,
everybody.
Jordi. Thank you, Jose.
My
It's the
pleasure.
last session of the Congress, so it's my pleasure to say thank you also to all of you. Thank you very much.